Our speaker for this session of updates in pediatrics is Dr. Kent Walker. Dr. Walker is a pediatric orthopedic surgeon with Norton Children's Orthopedics of Louisville. He received his medical degree from DeBuss College of Osteopathic Medicine in Harrogate, Tennessee. He completed his residency at Wellmont Holston Valley Medical Center in Kingsport, Tennessee. And he also completed a pediatric orthopedic fellowship at Campbell Clinic in Tennessee and Memphis. Dr. Walker enjoys treating all orthopedic conditions, including fractures, sports injuries, and foot and ankle problems. And he has a special interest in pediatric spine condition. Thank you for joining us today, and welcome, Dr. Walker.
Thank you. Thank you for having me. Yeah, I'm a pediatric orthopedic surgeon, but I do kind of specialize in spine specifically. And so it's a wide array of different fields within pediatric orthopedics. You can do sports, neuromuscular, you can do trauma, foot and ankle, and I kind of specialize in spine. So thank you all for having me. These are my disclosures. I'm a consultant for two different companies, but they are not relevant to this talk. And these are the learning objectives that you guys can refer back to. So adolescent back pain, I think probably in the last 10 to 15 years has become a much bigger proponent of your clinic than you all ever really wanted to. And I would tell you, oftentimes it can be the bane of our existence too, because these sometimes it's hard to pinpoint exactly what's going on, and it's hard to tell sometimes which one is important and which one is really just, due to poor posture. And, as you'll see some other things, but ultimately it's multifactorial. It's pretty high occurrence, about 28 to 48%, in school age children. And then athletes are more likely to have an actual injury, mainly an overuse injury, like a spondylolysis or some disc related pathology. But the most important thing is the history. Studies have shown that if you spend more than 2 hours studying, watching TV on your iPhones, iPad, TikTok, any of those, you're at a higher risk of back pain than the average population. And I think the most important thing to remember is like common things are common unless the presentation's atypical. And when the presentation's atypical, that's when your red flag should go up and you want to do a little bit more of a workup. And we'll kind of go over those different things in this talk as well. So the most important thing, like I said, is the history. So the timing, is it acute or is it chronic? So usually acute, you're thinking less than 6 weeks. Chronic, usually more than 6 weeks. And then always ask about the onset. I always ask about sports related. The question I always ask is it during sports or is it after sports? Anything that happens during sports and limits your activity, that's usually an issue. If it wakes you up at night, that's a problem. And a lot of kids will have pain during or after school, and that a lot of times makes you think it's more posture related. And then also the severity. And so if the patient loves sports, but they're like, you know what, I took 2 weeks off voluntarily, then there's probably a real issue going on. And the other thing I'll hear a lot of people say is like they don't even want to spend time with their friends and family because whenever they get out of the house, they have a lot of back pain. And that's usually something that makes me want to work it up further. Talk about the location, upper, middle, lower, and then midline and off midline. So upper middle, a lot of times is going to be more of your posture related. Midline, you're thinking more disc related. Off midline, you're thinking more muscle, possibly stress fracture, spondylolysis related, and we'll go through that. And then the frequency is always important. Sometimes I'll have patients in my clinic and it's like, well, how long have you had back pain? Well, I started about a week ago. And it's like, well, what brought it on? Well, nothing really. And then you start to ask them and they're not really active in sports. And you kind of find out like a lot of kids start to have back pain once school starts up or after the breaks because now they're forced to work on their posture. And that leads to back pain. And then always ask, does it radiate? Is the pain more in the back or is it more in the leg? And then you'll have some patients that say, well, I have back pain, but really I hurt everywhere. I wake up in the mornings, I'm sore. Nothing really seems to really help the pain. So then you're thinking more of fibromyalgia or hypermobility. Always ask about a recent illness. Even though rare, you can have discitis. I've been here 7 years and only seen a couple of these, but this back pain is very atypical. Patients will be hunched over. They just feel sick. They don't look good, and they hurt with any palpation to their spine. It's just not a normal reaction. Same thing with epidural abscess. Their pain is usually out of proportion. Like I don't understand why they're hurting so much. A lot of times the X-rays will look normal. Osteomyelitis kind of goes along those same spectrum. And then neoplasm is different, right? So if the pain wakes them up at night, the pain is worse at night, the pain is only at night, those are red flags that should start going off. And then pain in the mornings, you want to think more rheumatologic, like your HLA-B27, juvenile idiopathic arthritis, or any inflammatory type of back pain. If there's no injury, there's not an athlete, and they have poor posture, right away, I'm going to start thinking text neck or adolescent round back. So this is usually more posture related. And I'll be honest with you, that's probably more back pain that I see than true spondylolysis and true different disorders. And text neck has really come along in the last 10 to 15 years. But if you take a look at that picture over there, you can see the amount of stress that you put on the rest of your spine when you're looking over at your phone. And you can go as far as to say that this is really an epidemic in adolescents and young adults, but it's due to the poor posture while they're using their different devices. And it may seem like not a big deal, but this continued over years can actually lead to cervical degeneration. So you get essentially early arthritis in your cervical spine and your upper thoracic spine. And so we used to think of like the buffalo hump was more of like a Cushing type syndrome, or it was due to increase in steroids of some kind. But now we're actually seeing this more posture related due to this text neck. And so if you think your patient has this, probably don't need to get imaging right away. If they're not an athlete, there's no injury. Usually, you just kind of get them in physical therapy. But if they are an injury, there's an athlete who had back pain after some type of event, then that's when you would actually get a whole PA and lateral scoliosis x-rays. And the reason we get a PA x-ray is because that puts the heart when you're looking at the image on the left. And when we operate, the patient is prone. And so when we look at those images from surgery, we want them to be in the same position that they're lying in surgery. And so that's why we get the image in that projection. So if you think that they're probably going to need an pediatric orthopedic referral, if you could get a PA as opposed to an AP, it does help us because all of our sequential x-rays will be a PA as well. So like I said, usually address this in physical therapy. You want to address the posture and then the appropriate seating and standing positions. And so if you're sitting in class, hips and knees at 90 degrees, don't cross your hips or your ankles. If you can, try and have some lumbar support. And then the other thing is you want to adjust the position often. And so usually when I have a patient come in, they're like, well, what is good posture? I'll have them do a wall sit. And when they do a wall sit, I have them put their shoulders back, their head back, and it's really about lengthening their torso. And a lot of people will say, "Well, um, my dad always tells me pull my shoulders back, pull my." It's not just your shoulders; it's your whole torso. You want to lengthen your torso, and that's going to put your spine into a better position. And so that's what I'm talking about in the standing or seated position. When you're standing, you do want to bend your knee slightly. That helps increase blood flow as well. You want to have your shoulders back. And a good rule of thumb is to keep your ears in line with your shoulders. And so when you're looking down at your phone or your iPad or whatever, you're not keeping your ears in line with your shoulders. So I think that's a good thing to remember. And so when to refer. So if you see a patient, they have text neck, you get them in physical therapy or they're doing home exercise for 6 weeks and they're not getting better. That's a good time to go ahead and then refer to pediatric orthopedics. Adolescent round back is very similar. This is more of a mild hunchback, but also this is similar to poor posture. It's also known as postural kyphosis. It can be a normal variation, and it's not a disease. So Scheuermann's kyphosis, which is something that we'll discuss later, those patients cannot correct their kyphosis by standing up straight or lengthening their torso. These patients can. And like I said, this is similar to text neck. And a lot of times the parent would be like, they just slouch a lot and they have poor posture. And so you've seen this patient on the right here come into your office and they complain of back pain. And then what I explain to my patients and family is when you have good posture, 50% of the stress goes through the muscles and 50% of the stress goes through the discs and the bones. And so if that sagittal balance is off, well, now you're going to put more stress either through the muscles or more stress through the disc. And when it's through the muscles, you have muscle pain. When it's through the disc, actually start to get early degenerative changes. And so this is kind of what I was talking about when you talk about your balance. So in neutral balance, so you can I like to draw a line through the corner of the sacrum, and that should bisect through C7. Another way is to drop the line from C7. It should bisect through the sacrum. It really just depends on where you start. But essentially, positive balance is kind of like what you think of with text neck when the head is not centered over the pelvis, it's anterior to the pelvis. And the negative sagittal balance is when your head is posterior to the pelvis. But patients with adolescent round back will have this positive sagittal balance. And you can tell just looking at that, some vertebrae are going to take more stress from gravity than others. And ultimately, that's what it comes back to, gravity. The more stress that you put on from gravity, the more pain you're going to have. And so if this is a patient that comes in and they're not an athlete, they haven't had an injury, and there's no atypical back pain, then go ahead and get the PA and lateral scoliosis x-rays after they've uh, gone through physical therapy. But I think you don't have to start with an x-ray on these patients. I think you can start them in physical therapy first. And usually when we're writing a physical therapy order, it's strengthen the back and core and work on posture exercises. And then the physical therapist knows at that point what they want to look at. But this is a patient on the right where you can see they came in, they had postural kyphosis, they went to therapy, and just in therapy, they improved their sagittal balance, their posture. Now, if they had Scheuermann's kyphosis, which we'll talk about later, you can't correct that just by doing physical therapy. A lot of questions I get is, well, what about a mattress? Well, a firm mattress is better, but really, it's all about the support. So if you're going to lay on your back, it's nice to put a pillow under your knees. If you can get a pillow that puts your neck in a better position, that's good. And then really sleeping on your belly puts a lot of stress on your spine as well. And one of the things that I explain to the patients and their families that when they first start working on their posture, it's going to be really uncomfortable because those muscles haven't worked, haven't done what they're supposed to be doing in a long time. And so I kind of explain to if you haven't been to the gym in a couple of years and you go to the gym, those first couple of weeks, you're going to be extremely sore. But after you start going routinely, it's going to feel better to go to the gym and you're going to start to improve how you feel. So when to refer. So if you put similar to text neck, if you get them in physical therapy and they're not doing better after 6 weeks, then go ahead and refer them. And the other thing too is if you think you can't tell the difference between adolescent round back and Scheuermann's kyphosis or regular kyphosis, adolescent roundback will not have stretch marks. And if someone has kyphosis that is due to more of a bony problem, they're going to have stretch marks. So that would be a patient that you could go ahead and refer immediately. Um, and then the next type of patient you're going to see is the patient that have more back-related pain secondary to sports. And so we can kind of break those up into a muscle strain, spondylolysis, spondylolisthesis, disc bulge, herniated disc, and vertebral fractures. And we'll kind of go over each one of those as well. And so a muscle strain, usually the patient remembers it. The pain is usually pretty intense for the first couple of weeks with any movement. The pain's usually not midline. It's usually on the left or the right side, whichever muscle they've strained, or even thinking the oblique. And if you can kind of pinpoint the muscle and it doesn't feel like it's directly over bone, they usually don't need imaging either. Because after about 2 weeks, the pain should start to get a lot better. But I think the biggest issue that I see with patients with muscle strains is they do too much too soon. So when I tore my hamstring, I didn't run, I didn't do therapy, I didn't do anything for 6 weeks because you need to allow the muscle to heal. And if the muscle's torn or there's a strain, every time you stress it, you're essentially re-aggravating the injury. And so at earliest, get them into physical therapy at 4 weeks. If you can get the family to hold off, I think 6 weeks is better because what happens is once you're no longer in pain, you can make up those 2 weeks in therapy Whereas going after 4 weeks, you're still a little sore and you're not really progressing that quickly. But if they're still having a lot of pain after 4 weeks, that would be an indication to go ahead and send to us. Or if they say, well, when it happened, I felt a pop, there's always a possibility that it could be an avulsion fracture. So that would be an indication to get imaging or to see pediatric orthopedics as well. Um, and so, how do you know if it's a muscle strain? Um, so the other options would be a spondylolysis, spondylolisthesis. Spondylolysis, usually there could be an acute event where they say, "Yeah, I was playing, I fell, injured it," and that's exactly when it happened. The other thing is like, I don't know uh, when it happened, but my back, every time I play, it hurts. Every time I extend, it hurts. And so patients that do a lot of hyperextension are those patients. And then a disc bulge is going to be more midline pain. It's going to hurt with extension, but really it's going to hurt more with flexion. They're going to say it hurts to sit down, and they may or may not have radiating symptoms. A herniated disc is extremely painful. The radiating pain is going to be below the knee, whereas a disc bulge usually does not radiate below the knee. And then if it's an actual fracture, the second it happens, they're unable to finish practice. And this is the patient that comes into your clinic and you're like, yeah, they're miserable. And so all of those would be indications to get imaging. But let's just kind of break each one of those down and go into a little detail. So when you hear spondylolysis, a lot of people will refer to that as a spondy. Well, the issue is in the literature, spondy is a lot of different diagnoses. So it could be a spondylolysis you're talking about. It could be a spondylolisthesis. It could be a spondylosis. It could be spondylitis. For this talk, we're mainly going to talk about spondylolysis, which is more of a stress fracture, and the spondylolisthesis is actually when the spine slips forward. But spondylosis is arthritis, and spondylitis is inflammation in the spine. And so the spondylolysis, what we're going to talk about, it's an injury to the pars interarticularis. And I kind of think of this more as a spectrum or continuum as disease. And so what happens is it starts out as a pars reaction, which is just inflammation in the pars or the pedicle area, which then leads to a stress fracture. That left untreated can lead to a spondylolisthesis. And I think there's kind of a misnomer in the literature where it says that spondylolysis is a pars defect, and it's not really a defect. A defect is something you're born with. And what happens is normally someone will have a spondylolysis when they're a teenager. It can go on to what's called a fibrous union, where it heals, but it doesn't heal with bone. So when you x-ray it when you're 50 years old and you have back pain, you see this pars defect or this incidental finding. But in an adolescent, it is not a defect. It's not an incidental finding, rarely. It's in about 6 to 7% of the population, but of the patients that have back pain that are active in sports, 47% of those could have a spondylolysis. It's usually most common at L5, and the reason for that is we're the only mammals that walk on 2 feet all the time. And so we actually have lordosis at the lumbosacral junction, where other mammals have kyphosis at the lumbosacral junction. So we put a lot of stress at that L5 pars and pedicle area. And it's very common in hyperextension athletes. So your offensive linemen, gymnasts, cheerleaders, weightlifters, linebackers. But I've also seen it in all different sports, a lot of soccer players, a lot of basketball players. I've seen in field hockey, who's the complete opposite. They lean over a lot, but I've seen them have a spondylolysis as well. And so if you see the patient on the far right, that patient probably has an actual spondylolisthesis, and that's where it's kind of slipped forward. But they'll present usually with pain in that dark black area on that first image. They may have some buttock pain, but you'll see a lot of hamstring tightness. They'll have a positive stork. So a stork test is when you stand on your left leg, you grab your right knee with both hands, and then you hyperextend your lumbar spine. When you hyperextend your lumbar spine, a true stork test, when you grab your right knee, will hurt on the left, and when you grab your left knee, will hurt on the right, because that really isolates that area. They may have a positive cobra test. So if they lay on their belly and go into a cobra position, oftentimes that causes pain. They may have a palpable step off, which when you go and push on their spinous process, you may notice that it feels like one spinous process is higher in relation to the next spinous process. And that could be because they have a spondylolisthesis. And oftentimes, if you do get x-rays, you'll see that they have loss of lumbar lordosis. So if you ever get an x-ray and it's an extremely straight lumbar spine, that's an indication the patient has a lot of muscle spasm. That patient is in a lot of pain. So even though the radiologist may read it as a normal X-ray, if they have loss of lordosis, that's not a normal X-ray in my practice. And so this patient you do want to refer. And so here's the imaging that usually shows it best with the least amount of radiation. So in the past, they used to recommend getting oblique films, and that's when you would see the Scotty dog X-ray. But what we found out is that that's a increased radiation when just a lateral X-ray and an AP X-ray, two views of the lumbar spine, is going to diagnose about as many spondylolysis as you're going to get with the Scotty dog oblique X-ray. But it's a fracture in the pars interarticularis, which is where the circle is there. And if you're really worried about if they have instability, or like you're not sure if they have a spondylolisthesis or not, you can get a flexion extension view, and that shows you if there's movement at that disc, and you compare it to the neutral view. And then on the AP X-ray, it's not as evident, but you can actually see sclerosis on the AP X-ray. And so a CT scan is what's best to define the anatomy. I don't get a CT scan routinely. I like to use an MRI. I'll kind of show you why. But the CT scan increases radiation that an MRI does not cause any increased radiation to the patient. But you can see there'll be sclerosis in the pars area. This is a bilateral one. Historically, a bone SPECT scan was the gold standard. So it was a bone scan and a CT scan, but that also has a lot of radiation. So we're trying to decrease the amount of radiations that we are subjecting our patients to. And so I go ahead and get an MRI. Where I train, we actually did a study looking at MRI versus CT scan. What we found out is that a lot of times the MRI may not show the fracture, but it'll show inflammation in the pars and the pedicle region. And when you see inflammation in that area, that's a spondylolysis. It also tells you how acute it is, because there are times where you do see someone who's had a spondylolisthesis for a couple years, and then you get an MRI and it shows you, you know what, it's no longer in the acute phase, and the chances of it healing without surgery may be much lower. But it also shows you if there's any disc pathology, and it shows you a lot of other things that the CT scan would not show you. And so in my practice, they get two views of the lumbar spine, and then if I'm still concerned about a spondylolysis, I get an MRI. So there was a study that came out in 2017 that kind of looked at the sensitivity of a CT scan was 85%, of an MRI was 80%, and they recommended that time doing a two-view plain film. Um, if you're not sure of the diagnosis, early on get an MRI, and then if the MRI is normal and you're still concerned about a spondylolysis, that's when you would go ahead and get a CT scan, or for surgical planning, to let you know if, because oftentimes you could have a unilateral spondylolysis versus a bilateral spondylolysis. So this was back in 2017. Our MRI scanners have gotten better since then. And so I think the sensitivity is even higher. What I've noticed, though, is some of the younger radiologists have been trained on this, and some of the older radiologists are still in the process of learning this. So I look at all my MRIs, and even though an MRI may be read as normal, if there's inflammation in that area, then they get the diagnosis of a spondylolysis. And so that's kind of what this talked about really back in 2006. So it's taken that long to really catch on, that an MRI can diagnose these. And I was just in a talk the other day, and they said it takes about 17 years for a new topic to be addressed and then essentially be accepted in the medical field. So we're kind of in that area now. So 17 years from 2006, it's about 2 years ago. So makes sense. Then left untreated, a spondylolysis can turn into a spondylolisthesis, which is an anterior subluxation of the vertebral body adjacent to the inferior vertebral body. So if you look at the picture there, that's essentially L5 on S1, and you can see a grade 1 is less than 25%, grade 2 is 25 to 50%, grade 3 is 25 to 75, grade 4, 75 to 100, and then you actually have something called a spondyloptosis, and that's where it's slipped completely forward. And not only can it be slipped completely forward, but I've seen it slip completely forward and then fallen in front of the sacrum. And so that can be kind of a very tough situation to deal with, because that's one that you actually can't make better, unfortunately. And these are really more for your orthopedic, the different angles that you would look at when ordering an X-ray for these spondylolisthesis patients. But what you want to do is you want to look at something called the slip angle, the pelvic incidence, the pelvic tilt, and the sacral slope. And what that does is that tells you the risk that the spondylolisthesis is going to get worse without any intervention. And that's really what these next couple X-rays are showing. So we don't need to go into that too much, but you can kind of see as those angles increase, it's more likely to slip. And I think that's just in relation to gravity makes sense. And then once again, just a little bit more of that. That's just more for completeness sake. So we kind of talk about treating both of these at the same time. So a spondylolysis, the majority of patients who have a spondylolysis will not need surgery. In my office, it's less than 5% is going to go on to surgery. Now, if you have a spondylolisthesis, that number goes up. You know, you can observe it. The way I look at it, though, is if they're in my office, they're probably not asymptomatic. And so very rarely am I going to observe a spondylolysis. If they're symptomatic, what the literature shows is that if you get them to stop sports for 3 months, the chance of them returning back to play is significantly, it's over 90%. What I have found out is that if you can get the patients to wear a brace for 6 weeks, take them out of sports and do physical therapy, the chances of getting them back to their sport at the same level is over 95%. But the biggest thing is you want to work on hamstring stretching, pelvic tilts, abdominal strengthening. And then the bracing, I use an extension LSO. And the reason you may say, well, if they're hyperextension athletes, why would you use an extension LSO? Because when you put them in just a little bit of extension, that actually recreates the sagittal profile better than just a neutral brace. And what we found is that brace immobilization is superior to just stopping sports alone. And part of the reason I think is because when you put them in a brace, they're not going to play at recess. They're not going to mess around with their buddies because they'll know, remember being in the brace, that they can't do anything. And so when you get them into therapy, you can't just get them into back pain therapy. That's where a lot of these patients end up getting worse, is because the first 4 to 6 weeks of therapy is very, very simple. It's just working on posture, it's working on breathing. I don't add strengthening in their physical therapy until after 2 months. And so what we want to do is get them in the brace for 6 weeks, get them into therapy. So when they come out of the brace, they're not so deconditioned from the brace. And then one of the things I tell them is they need to work on communicating with their physical therapist, because if they're sore the next day after therapy, that means the therapy session was too intense. If they're sore afterwards, that's normal. Ice it, take some ibuprofen, some Tylenol if you need it. But if that soreness lingers into the next day, well, that means they weren't ready to do what they did that day. And so let's say you have a patient who went through, 3 months of physical therapy, didn't get better. You could offer them a PARS injection, which is essentially a steroid injection in that area. And then the next step after that would be surgery. And you can do what's called a PARS repair. And so what that means is a repair is you are not fusing the spine. So you're allowing motion or preserving motion, whereas a fusion is going to stop motion in that area. So historically, you could do PARS repair at L1 and L4. And they didn't recommend it if the patient had degenerative disc disease, though. And then fusion at L5S1 was the recommendation. And if they had a high grade spondylolisthesis, so greater, like a grade 2 or more, then they actually recommended an L4S1 fusion. And so when you get an MRI, you want to make sure that you're looking at the disc at L4, L5, and L5S1, because if I have a patient who has a spondylolysis at L5 with a lot of disc degeneration, well, then you're going to do a fusion. And now historically, doing a repair at L5 was kind of controversial, but now that we have different types of implants, there's been some good literature showing that you can do a repair at L5 and have very good results. So that's something that I like to do. It preserves the motion, but if they have a bad disc at that area, if you just repair it, I think they're going to have continued pain because they'll have pain to the disc. If they have a high-grade spondylolisthesis, you want to do an L4 to S1 fusion. And there's some controversy of whether you should reduce the spondylolisthesis back to normal alignment. And the issue was that in the past, people would reduce the fracture, but they wouldn't decompress the nerve roots. And so they would have nerve pain after surgery. So I actually do this with neurosurgery. I have them decompress the nerves, then we reduce it because I think restoring their balance for long-term back pain is the most important thing we can do. And so this is kind of what I was talking about historically. A pars repaired L5 was kind of controversial, but with the newer implants that we have, this person was able to have an 84% fusion rate with the repair. And I'll say I've had the same type of success with my patients as well. But when they recommended not doing that is if the patient had spina bifida occulta, if their gap defect was bigger than 2 millimeters, or if they had disc degeneration. And I think if you see a patient who has spina bifida occulta and a spondylolisthesis, that's the patient that might actually have had what we call pars defect, and I think that's part of a bigger spectrum. But the majority of the patients that we see are going to be sports related. And so this is something that I think we can offer our patients and help preserve motion. And so this is kind of a picture of it. And one of the things I talked about earlier was the sclerosis that you may see on the AP. So if you can see my arrow, you can see this circle here is a pedicle, and this circle here is the pedicle. But these pedicles you do not see as well. That's the sclerosis that we're talking about that may indicate there's a spondylolysis. And so, I can see it here. There's a spondylolysis here, but the CT scan really shows the spondylolysis. And also, there's a grade 1 spondylolisthesis here. And so this patient, they were able to do a pars repair because it was a grade 1 spondylolisthesis, but the disc was healthy. And what they did is they put a pedicle screw in at L5 on both sides and a lamina hook. So what you'll see is that they did not put screws down at S1. So technically, they did not fuse any segments here, and so they should not have lost any motion. Next thing is disc bulge or herniated disc. So this also is usually going to be an acute back pain, but their pain is going to be midline. It hurts if you push in that area. Really, if you push on it, pain may even radiate down low, but it's going to be worse with flexion. And these patients are the patients that just seem like they're in your office and they just can't seem to get comfortable no matter what position they're in. And they're so the way to determine the difference between a disc bulge versus a herniated disc is a herniated disc is going to have all three of these are probably going to be positive. So you have a seated straight leg raise, that's going to be positive, a supine straight leg, that's going to be positive, and then a contralateral straight leg raise. So if the pain is on the right, but you lift their left leg when they're lying supine and it causes pain on the right, that's usually an indication that they're going to have a herniated disc. A disc bulge and even a herniated disc does not mean surgery. Usually, a disc bulge will get better with 6 weeks of rest, anti-inflammatories, and similar to a muscle strain, I do not put these patients in therapy for 3 to 4 weeks because the PT is just too painful. Anything they do causes pain. So if you can control their pain, the gains that they get in therapy is going to be much better. And then if they're not better after a couple of weeks, then go ahead and get lumbar x-rays. A lot of times the x-rays will be normal, but you may see what's called a retrolisthesis. So that's the opposite of a spondylolisthesis. That's where the spine actually goes backwards. And the way I explained to people was it's actually the bone is like trying to grab the disc because the disc is trying to go backwards. I was taught that a retrolisthesis really didn't mean anything clinically, but I'll tell you in the pediatric population, if a patient has a disc bulge and a retrolisthesis, they have significantly more pain than just a disc bulge. And so I'll always get an MRI if I'm afraid that there's a disc bulge in these patients because I want to make sure that there's not a herniated disc that needs to be decompressed. And if there's not, usually therapy, and then they can ease back into sports after 6 weeks. And really, it's just pain, let pain be their guide. And so here's what I was talking about, this retrolisthesis, especially in B. You can see that the spine is slipped backwards in relation to the one below. It's not slipped forward in the one to the relation below. And so that's because it's trying to go with the disc. And so if it's not better with therapy, I'll brace these for 6 weeks. I'll give them a Medrol dose pack. If they're still not better, we can do an epidural injection. And then the last option is a discectomy. I try not to do discectomies in pediatric patients too often because it just sets them up for more surgery later on. And then lastly, within this subset of groups is vertebral fractures. And so just like any patient, they may get an injury, they could be in a car accident, you never know. But the three main things you're going to look for is a spinous process fracture, a transverse process fracture, a compression fracture. These patients, very similar. They're going to have severe pain. Oftentimes they're not going to be able to get up. They're not going to be able to walk. They need to be seen in the emergency department. They need x-rays. And possibly CT scans. You can see here, this patient has a spinous process fracture. Upper right, that's a transverse process fracture. And then here down below is a compression fracture. Um, Usually, the majority of them will not need surgery if it just involves the one column of the spine. So the way we look at the spine, we break it up into three columns. So you have your anterior column, which is your vertebral body, your middle column, which is kind of the area where the pedicle and the spinal cord is, and then you have the posterior elements, which is your spinous process, your transverse process, your lamina, your pars. That's considered your posterior column. So if the fracture just involves one column, rarely do they need surgery. But if it involves all three columns or there's a ligamentous injury, which you would diagnose on an MRI, that's when they would need surgery. But those are kind of chance fractures, burst fractures. That's a spine trauma is a lecture in itself. And so then the next thing to look for is atypical back pain. And these are the patients that need an urgent referral or they need to just go straight to the emergency department. So your patients with discitis or vertebral osteomyelitis, the parents may describe that they had gradual onset of irritability. Then the next day they woke up, they won't walk, they won't crawl, any pain, any movement causes severe pain, but really bending forward. And then they may have a fever or maybe even just a low grade temperature, indicating that there's an inflammatory or infectious process going on. These patients are usually younger because there's increased blood flow to the disc. When you're younger, the capillaries move slower as well, so the blood stays in that area longer, and so it's more likely to get an infection, whereas adults don't necessarily have that issue as well. If an adult's going to get it, it's usually going to be related to IV drug abuse or because they're immunocompromised. When you get the imaging on these patients, it may be normal. And that's why if the atypical back pain presents in your office, you may want to get x-rays and go ahead and refer anyways, because if something doesn't seem right, then oftentimes it's not. Luckily, treatment is usually with antibiotics and not surgery. The most common organisms are Staph aureus and Kingella. Now, if it's an epidural abscess, it may be similar, but oftentimes they may have a neurological deficit because it's pushing on the thecal sac, which could then be causing a neurological deficit. These patients are usually immunocompromised. Once again, they may have normal radiographs, but the MRI with and without contrast is going to help make the diagnosis. And because of the abscess, this patient does actually require surgery. If you're worried about a neoplasm, it's going to be in the patient who comes in and they can't remember when they injured their back. They can't even really describe to you the back pain. It just hurts all the time. They don't really know where it hurts. They have back pain that's worse at night. It wakes them up at night. They may have fever. They may have night sweats. They may notice some weight loss. They may be myelopathic. So what that means is if you watch them walk, they may have some instability or they may be extremely weak. Go ahead and get labs on this patient. What I like to start with is the CBC and ESR and the CRP. That just kind of lets you know the inflammatory. If all three of those are abnormal, if there's a elevated white blood cell count, a CRP and an ESR, and a left ship, that patient has an infection until proven otherwise. You need an MRI with and without, infection or neoplasm, MRI with and without contrast, and then these patients need to be admitted. And then I've seen a couple patients after the fact. I haven't seen them, but this is one of those diagnoses just to kind of have in the back of your mind. But transverse myelitis is a patient who has acute progressive onset of back pain. They have bowel and bladder disturbance and they have sensory motor deficits. So if they come in and they're just, mom is like, they were running yesterday and today he can barely lift his leg up. So the patients with infection oftentimes can't walk because it hurts. these patients oftentimes can't walk because their spinal cord's been uh, disrupted. And so this is another contrasted MRI, and this patient needs a lumbar puncture as well. So this group of patient is atypical back pain, but they need to be referred to a neurosurgeon first and then a pediatric orthopedic spine surgeon. That's when you're worried about a tethered cord syndrome. So what I explain to my patients is I'm a bone spine doctor. I'm not a spinal cord doctor. And so if you have patients that come in, they have back pain with exercise in addition to these diagnoses. So if they have any bowel or bladder incontinence or constipation, diminished or absent reflexes, if they were toe walkers when they were younger, if they have spina bifida occulta on their x-ray, if they have extreme hamstring tightness, calf atrophy, or toe curling. Toe curling may actually be a sign of spina bifida occulta or very low lying spina bifida that actually goes along with the tethered cord syndrome. Um, and so then back pain that's really not orthopedic back pain would be your fibromyalgias, your hypermobilities, and your rheumatologic. So kind of think of someone comes in, they've had back pain for over 3 months, they're tired, they're weak, they just hurt all over, they have multiple joints that hurt, they're kind of tender to touch. Usually someone who has a spondylolysis, you have to push pretty hard to elicit pain. They'll say that they don't sleep well. If you notice that they have some vasovagal symptoms, so when they say they stand up, they get lightheaded, they may have morning stiffness, they may have SI joint tenderness. These patients, once again, go ahead and get a PN lateral scoliosis x-ray. And so I think getting the two views scoliosis just tells you so much more about that patient than just one view. When you're ordering labs, HLA-B27, ESR, CBC, CRP, you can do rheumatoid factor testing. And then you want to refer these patients either to the hypermobility clinic and or pediatric rheumatology. But I don't think these patients are the best to start with orthopedics, as the majority of them are not going to have an orthopedic issue that needs to be surgically addressed. And then this is another patient that comes into your office and they're complaining of back pain, but when you isolate it, the back pain's actually over their iliac crest. And so what they did is where the oblique muscle attaches, it pulled off and caused an avulsion fracture over the iliac crest. And this is similar to an oblique strain. It may be tender along the iliac crest and not actually along the muscle itself. So when you palpate that patient, if it's a muscle strain, you're not going to feel bony prominence under there. Whereas if it's bone related, you should feel that bone. You may not be able to know exactly what bone you're feeling, but you should be able to tell the difference between a bone and muscle with palpation. These patients, it's usually athletic related, and then they're pretty painful. So anytime they try and progress back to sports, they're like, I can't really do anything. And this is the patient that when you take them out of sports, they're really not that upset because they knew in the back of their mind that they weren't um, in best condition to move forward anyways. And so go ahead and refer these patients to us. We usually take them out of sports for 3 months, and that's a long time. But I played college soccer and I had a similar injury to this. And I didn't go to the doctor, and this took me about 6 to 9 months to get better. So 3 months is significantly better than 6 to 9. This is just kind of a picture of the different areas where you can have an avulsion fracture. It's kind of a neat iliac crest from the abdominal muscles, the anterior superior iliac spine from the sartorius, the anterior inferior iliac spine from the rectus femoris, the symphysis from the adductors, the ischial tuberosity from the hamstrings, the lesser trochanter from the iliopsoas, and the greater trochanter from the glute medius and minimus. And so then you have patient come in, they have back pain, you do the Adams Ford bending test, and you're like, okay, they have a curve. This isn't normal. So Scheuermann's kyphosis, like we talked about, is poor posture that cannot be um, cannot be passively or actively corrected by themselves. These patients usually have daily back pain. They have a significant hunchback deformity. They'll have stretch marks, and go ahead and send that patient to pediatric orthopedics. The true diagnosis is a radiological diagnosis where you'll have greater than 5 degrees of wedging at 3 different vertebrae in the spine. And you can kind of see these vertebrae here. They're not boxed like the regular vertebra. And so that's where they start to get early degenerative changes. Normal thoracic kyphosis is 20 to 45 degrees. We recommend bracing if it's over 55 degrees and they're still growing. And then we will offer surgery after 75 degrees. But I explained to the family of the patient, this is not Scoliosis is a disorder that if you don't treat it can lead to lung and heart disorders. Kyphosis doesn't do that because it doesn't decrease the space of the thoracic cavity. And so if a patient wants to proceed with surgery, it's usually when they have extreme pain. And so I tell them when you have more bad days than good days, that's when we'll discuss surgery because you can see it's a pretty big surgery. And then scoliosis, the book will tell you scoliosis doesn't cause back pain. But I'll tell you, whoever wrote the book probably didn't have scoliosis because I have a lot of patients with scoliosis that have back pain, and I see a lot of patients without scoliosis that have back pain, and the type of back pain is usually different. And so I think essentially what they deduced was that 40% of the patients that don't have scoliosis have back pain, and 40% of the patients with scoliosis have back pain. So scoliosis doesn't cause back pain. And I don't really feel like that's very intuitive, deductive reasoning. But especially if the curves are over 30 degrees, I've seen that they'll start to have a little bit more back pain. So once again, if Adam's for a bending test, you see that one rib hump's higher than the other, or you see that there's some lumbar asymmetry, go ahead and get an X-ray, but get a PA and lateral scoliosis X-ray. If the curve is under 25 degrees and they're skeletal mature, the risk of progression is less than 1%. So anyone who's still growing and has a curve over 10 degrees, that patient can see orthopedics. If they're already if it's a girl who's 16 and they have a 15-degree curve, the chances of that curve getting better is less than 1%. Unless the family just really wants it, that patient really doesn't have to be referred to pediatric orthopedics. Um, and so I explained to them that the Scoliosis Research Society defines scoliosis as anything over 10 degrees, and anything less than 10 degrees is spinal asymmetry. So I have patients come in and I'll say, well, they don't have scoliosis. And the family will say, well, look at the X-ray. I can see a curve. And I say, well, I agree with you, but that's less than 10 degrees. And then scoliosis is then further broken down into early onset scoliosis, which is under 10. You can have infantile idiopathic scoliosis and juvenile scoliosis, which is 3 to 10. And I think from a time standpoint, I think that's kind of the patients that we're going to kind of key on today. The rest of these slides were if we were up against time. So I think we can go ahead at this point and see if anybody has any questions, and we can address those now.
If anyone has any questions, if you would put them in the Q&A box or at the chat, let's see. I do not see any questions. All right. Well, thank you, Dr. Walker. This program will be online in a couple weeks, a week after Thanksgiving. I want to thank everyone for joining us. We will be sharing a QR code that has the evaluation attendance link, and it is also in the chat notes now. And we'd like to invite you to join us for the December 17th issue, which will be on pediatric hearing loss. And there is a registration link in the chat box as well. So thank you everyone for joining us, and have a great Thanksgiving. Thank you, Dr. Walker.
You all.